So the preparation for taking a cardiograph is to have the patient rested, ideally not with a cup of coffee before the treatment or having run or been stressed at all before. And the most important thing is to find the right point. And the right point we're going to use at this particular stage is called Erb's point. So we're familiar with this, that it's in the space of between the third and the fourth rib, close to the sternum. That's where we listen to. Now, as we'll see in a little later, where the valve positions are, but this sort of is like a central point, so you're really listening to all and getting a good referral of the sounds of each of the valves. So this is usually the best place to do this. We do the test sitting if you're using a phonocardiograph. If you're using an ordinary stethoscope and you're just playing it straight back, and then you do it with the patient supine. But in the case of doing the phonocardiograph, it's best done sitting. Have you done it?
Did you want to start?
Yeah. So she's putting the stethoscope in her ears, she's switching it on, it's as simple as that. She's choosing the diaphragm, the dome as opposed to the diaphragm, because the diaphragm is usually more for lung sounds, the dome picks up the heart better. She has a listen to it. If it's very quiet, she can press the amplifier on the digital stethoscope. If it's not so quiet, then we switch it off because you get too much background noise otherwise. So she should be on Erb's point and hearing that. And what she's now doing is, do you want to flick on to switch? We should be able to see now it recording. You want to switch on to that computer? That's it. Okay, delete it and we'll start again. Okay, just delete it. Let's go back to this. So, patients sitting, and in the case when it's soft, get them to bend forward, to lean forward, so that the heart literally goes in a forward position. When do I do this? What I usually do with the patient, preliminary-wise, after you've done the case history, I usually do the coloured acetate to determine that they're pure red, green or blue on both sides. And then we do the therapy localization, greater wings of the sphenoid, left, right. And if they're got a mixture, what we call a hybrid, then I'll do the mirror-on light and get that back so that we're programmed as they should be. And at that stage, you can do the phonocardiograph. Or you may choose to do it a bit later on if the patient's come in with, say, a digestive problem or a bad back, nothing to do with the cardiovascular system at all. You may choose not to do this at all or to do it later on. But whatever you find in however you examine the patient, you will find it in the heart. Okay? And that's the important thing. The second important thing is it links the emotion, as we'll see later on, very strongly from the heart to the mind and vice versa. So this is why the heart is such a good central area to start your examination. But let's not forget, if the patient has a bad back, they want you to have a look at the bad back. Okay? You may be important, you save their life, but they've come to see you about the bad back. Okay? So don't forget the areas of where they've come to see you about the areas of symptoms there. Are we ready? Oh, you're doing it. Okay, flick on if you would. So if we have a look now, are you still doing it?
No, I've done it.
All right, okay, so let's have a look at what we've got there. Okay, so let's have a look. Can you play it? Is it playing it or is it playing the top one? You can't hear anything. No, switch it off. No, it's all right, we'll leave that one. Just switch it off. Lose it. Yeah, come out of it and do it again. But switch it off so you re-screen it. Okay, switch it off. You've got a lot of interference in there. We'll take that one out, I think. See if we can get it to work a bit better. Okay, off you go, just do another one. Okay, so keep that one running and see if you can get the sound. No, you got too much. There's too much interference here. Okay. So let's. I don't know where it's coming from. It's not.
That's the train line.
It could be the train line. Yeah.
First time it was better.
It was fine. Yeah.
Yeah.
So let's.
Come out of that. Let's try again.
No, it's all interference on there. Just what's disconnected? The what? The mains is disconnected. Yeah.
Why don't we try the Jill does the recording away from the...
I'm going to take you out, or your plug out, and see what happens. No, it's in the computer. Try it again. Oh, we're getting a recording, that's good. Even if you can't hear it, we're getting a recording, that's good. So don't worry about the fact you can't hear it. It's because I've unplugged it.
Can you hear it through your headphones?
We will, yeah. You keep going, go for another 10 seconds, Joe. Okay, the reason we're keeping going for 30 seconds or so, okay, you can stop now, is we want to see if there's any variation in the rhythm. Okay, we can see there's a variation in the amplitude, can't we? But we want to see if there's a variation in the rhythm, are the beats, because apparently she has or had arrhythmia and other problems. So if we flick back now to the beginning, so what we do is we'll just run this through back to the beginning. Now remember golden rules when we look at x-rays, when we look at anything, we have to remember what is normal, what we look for. And the two most important things that we look for is the amplitude of the first to the second sound should be twice the height, and the period of time between the second sound and the next first one should be twice the size, twice the length of sound 1 to sound 2. Right? So how do we determine which is the first sound and which is the second? Because I got this really muddled up in the early days of doing this. What was first and second sound? You know, I thought all my patients were having heart attacks because everyone had a short resting period. But in fact, it was the period between the first sound and the second sound, because the second sound in the majority of my patients was bigger than the first sound. So I jumped to the conclusion that was the first sound, but it wasn't. It was the second sound. So you look for the gaps. This is the best thing. And as I cast my eye across, I can see the gaps are twice the size alternately. So in other words, this is the second sound, this is the first sound, there's our rest, there's our first sound, there's our second sound. Do you see what I mean? So you can begin to pick it out. That's the first thing. Okay, now, if we do that, that first sound there is almost non-existent. What does that mean? What's the first sound? The first sound is the contraction of the ventricle. Gosh, you know, let's put her on the track now, shall we? So she's belting off the track on full pelt, but she's not producing any contraction. There's no volume coming out of there. Right? This is a bit better. Better. Bad again. Second sound wallops up, probably as a compensation. The blood pressure's going up here. Disappears on the other side there, and then the second sound almost disappears. Okay. Then the first sound down, down, down. So roll on, Jill, and let's have a look. Now, stop there. See this one? What did I say when the first sound is split? In other words, the bundle branch, the two sides of the bundle of hiss, are firing slightly, microseconds apart. You get that extended first sound. So you get a thickening of the first sound. See, she's got a slight bundle branch there. But it's no problem because it's not in every one. If it was every beats, then you'd say, well, this is significant. But it's not significant here. We've got a few bundle branch. Microseconds of difference here. But again, very poor first sounds. Go on again. Stop. First, second. Slight, as I say, bundle branches coming in here. But generally, the good thing here is it's rhythmical. Okay? So let's go on and let's see. I'm sure during the day we'll find somebody who's not rhythmical. Okay, Stop there. Okay. So generally, good, you'll live, okay? But she won't be living as effectively if she was on the track. Okay, she'll muster along. What do you like with exercise when you exercise?
I can't run.
You can't run, no. So we've told her that. She will be... The worrying thing is most of the athletes, we have a look at her like this. And, you know, some of them, that first sound, you know, you can see when they're really belting away and there's hardly any first sound. And then it comes in enormously, you know, to try and compensate for the, you know, the hypoxia, really, on there. So this is nice and rhythmical. It's what we find mostly in probably 80% of the cases, it's a muscular problem to do with the contraction of the muscle. And we find most often it's when people go from that up and down to indicate it's a hypoxic situation rather than a nutrition to the left and up. So it's usually a nutrition that helps the hypoxia, but in this case what I tend to find it's more not that they're deficient in their diet, but they're deficient in absorbing and getting it to work. So what we do now is we'll pop her down with your head this end, if you will. So we'll get the headphones out now. And what we've done now is to feed that information back to her through the headphones, or if you've got a stethoscope, you can put it out through the stethoscope. We'll take that stethoscope out and minimise the interference. Do you want to just test her subscapularis muscles first? Mm-hmm. So we want to show you on the left here, we'll do a subscapularis muscle test. All right, so she's keeping the hands out. Okay, so Jill's getting her to push her hand towards the floor. So standard on the left and on the right. So she's nice and strong. Okay, you need to make sure that that's the case first of all. So what we're going to do on the here is we plug the headphones in, and it's beating really nicely there. So we pop those on the ears. You know, don't have two headphones which are too tight. You don't want to create a cranial fault, do we? Okay. So if you like to test those muscles again, the subscapularis on the right. Sorry.
Nothing here.
There's nothing now on that side. Okay, it's gone completely. Okay, now try it on this side. Okay. Okay, so she's weak on the right. Okay, this will probably indicate that she's acting a little bit on the left brain dominant at the moment, because when you're right brain dominant, it tends to be the left one which stays strong, that goes weak, mainly because the afferent back from the heart to the brain is ipsilateral. It doesn't cross over, it goes to the cerebellum through the vagus and things, and so it tends to be on the same side. Okay, now you just hold on there. Let's go back onto the slides here. Okay. Now the frustrating thing with this is you have to use a subscapularis, and for me, subscapularis means we're occupying a hand, and hands can do other things far more useful to us than just be used for muscle testing. So we need to hold things, we need to cross therapy, localize and so on. And what I couldn't understand is why it was that the person doesn't weaken universally, but only the subscapularis, which is what Dr. Goodhart taught us, that there is only one muscle related to the heart, and that's the subscapularis. And it could be on the left or could be on the right. So I want to know, see if there was a way that we could get it to weaken generally universally there, because she won't do that. If you test the quads now, so headphones on, so she's listening to it. Now if you remember, what she's doing is she's listening to the heart. So we're bypassing the input through the midbrain, and we're taking it straight into the temporal lobes of the cortex. And from there it's going to the parietals and the frontal cortex, to the frontal orbital parts of the frontal cortex, so she's actually consciously thinking about and listening to this.
And they're both strong.
They're both strong, as they should be. Okay, now, let's digress a minute. We saw earlier before the break the importance of magnesium as the voltage channel regulator to allow calcium into the cell. Now this is very important because this would be an ionic form of magnesium, like an ionized form of calcium. Now, if we could reduce the function of the magnesium voltage channel, we may be able to get her to show up, or the patient to show up, a more universal weakness. And the interesting thing is that beryllium, as an element, is an antagonist, direct antagonist to magnesium. If you look at it on the periodic table, it's right next to it. Beryllium, there's approximately 35 micrograms of beryllium is found in the human body, but this amount is not considered harmful. Beryllium is chemically similar to magnesium and therefore can displace it from enzymes, and it can displace it from that protein kinase enzyme, which causes them to malfunction. The trouble is beryllium is highly toxic. It's used for military purposes in weapons and aircraft and things. It's a highly toxic substance. But you can't just put beryllium on the tongue. Notable sources of beryllium, and I had no idea about this till investigated, are beryl, which is otherwise known as aquamarine as a substance, and emerald. Emerald is beryllium, or very rich in the beryllium salts. And chrysoberyl, which is the last one, which is a colourless one. So emerald is green and aquamarine is that lovely turquoisey colour. So what we've done is we've got there emerald, which is simulated into the charcoal. So if you pop that on. Now, what we have to do with this is you take the headphones off first. Okay, now you put the beryllium on, and then you place the headphones. Well, actually, just test her for the beryllium, make sure she's not allergic or sensitive to the beryllium or to the emerald. Okay, now we put the headphones on. Just test now any muscle you want. Everything goes weak. Okay, but you can see if we do it around the other way, if we take the headphones off, take that off, put the headphones on, and now put that on, she won't go weak. Okay, you have to have the emerald on first. So that decreases the function in some way, I think, of the voltage regulators of the magnesium. So you must put them, once you've done your recording, check them that they're not sensitive to the emerald, put the emerald on, and then put the headphones on, and hey presto, you're in weakness. Now we can find out everything that's wrong with her. Okay? She's in weakness and we can use her quads, whichever muscle you want to use. Okay? So that's a big breakthrough, because that makes us treating our sports people much easier and our other patients, because we've got two hands free now. They can hold things and they can cross therapy localize. So what we would do here is to try and see what it is that's going to get her back working together again. In other words, what negates this weakness. Okay? So what we'll do is we'll have a look. Do you want to do that? You do it each time. You don't need me. Okay, so we're going to do the eye tracking. So first of all, she's going to follow the eye to the left and up. So she's going to left and up. And left and up is always for nutrition. Okay, so it's indicated she could be deficient in something. So yes, okay. Now do a cross, because she may come up with 2 or 3 things. So with this, you get the whole lot out in one go. So it's not surprising sometimes you get 2 or 3 eye positions that will show up. Toxin, so she's deficient, she's toxic. Might as well go for structure next. Now I would have, so probably structures are, I would have done cranial before by just putting the acetate on, checking her preliminary that she's left-right, that she's green-green or red-red, whatever she is. But now we might as well do the cranial. So how would we test the cranium? Inspiration. So take her to breathe in, shout up. She won't hear you.
Yeah, she did. Breathe in.
It's no good muttering to yourself when they got the headphones on and listening to bum, bum, bum. No. So inspiration. Did she strengthen at all? No. Okay, so we can exclude cranial. Okay, allergy or intolerance? That's what the lads in the cars have. They're listening to heartbeats in there. That bum, bum, bum as they go past, you know. It's not music, it's the heartbeat. Yes. No. Okay, exercise? Now, exercise, interestingly, does show up often with cardiovascular problems, because people need sometimes to exercise. And one of the things that they feel is they feel better when they exercise. So people say, I go for a walk, good brisk walk, or a run, and I feel much better. They come back and they say, I spend a day in the office and I get worse and worse and worse as the day goes by. This is hypoxia. These are people who are hypoxic. In other words, they're lacking oxygen into the tissue, and they increase the oxygen intake by exercise. So this is when exercise will show up often. Okay, to the left and up for dehydration and possibly pH acidity levels. No? Okay, and then round and round. This is the hardest one for people to do, isn't it? To actually track round and round. That's for infections. So we've got toxins and we've got nutrition. No cranium. If we'd seen a cranial fault there, okay, and then up and down. Yeah, so we got, so the cause of the hypoxia may be the nutrition or it may be something else. So when we clear any one of those, we've got to then go back and check the other ones, all right? So each one we clear, we've got to make sure we cleared the other ones. Because there could be two things related to nutrition, one more for hypoxia and one more for the nutrition, because two eye positions are shown up. So the fact she shows toxins, I think we should deal with toxins first. Because you can build up all the nutrients, but if she's got toxins, we've got to detoxify her, okay? Otherwise you're just pumping in water with the plug out. So what we need to go for with her will be for toxic metals, chemicals and radiation, and then see which one it is and the length. Now if it had been a cranial fault, what we would have seen is a much more amplitude up, all right, increased amplitude, and then down in a rhythmical way as she breathed in and out. Okay? So remember, this is the amplitude of the contraction. The force of it is much greater. All right? Now, if you just feel your pulse, just to have a feel of your pulse on your wrist, and just get aware of it. It should be around 72 beats a minute, give or take a bit. Okay. Now breathe in really deep and hold it. And now puff right out. And hold it. Okay, now breathe normally, all right? What should happen normally with heart rate variability is the pulse rate increases, just a small amount, but on an E-wave meter you can detect that to the heart wave variability. And it may go from 72 to 73 or maybe 74, okay? Not a vast amount, and on expiration it could go down to 71, 72. Okay, and what you see that then on a heart rate variability is a nice up and down on a graph like that. Okay, but so often what you see is incoherence all over the place. Okay, so what we know is that if our beat should be 72 times a minute, what is it that maintains that inherent 72 times a minute, and how come I can go faster and slower over the normal variability? How come I can go way up to 80 and way down to 65? You know, within a couple of beats I can be all over the place. The answer is the sympathetic nervous system and the parasympathetic nervous system. So we have a regular inherent control which is then overridden by the sympathetic and the parasympathetic, which both come from, ultimately, from the brain. So the brain is overriding the heart. So the heart can be nice and regular, but it's normal to go up and down a little bit with heart rate variability with breathing, but not to go abnormally high or abnormally low or irregular. So it means irregularities are neurologically generated, okay, from either here or within the nodes themselves in the heart.